APhA supports structural, financial, and operational separation of pharmacy benefit managers and pharmacies, including policies that require divestiture of vertically integrated pharmacy ownership interests across PBMs, insurers, and affiliated entities, to eliminate conflicts of interest inherent in vertical integration, prevent self-preferencing and anti-competitive practices that increase patient and total costs of care, protect patient health and safety, reduce morbidity and mortality, ensure timely, clinically appropriate access to medications, support fair and reasonable reimbursement, and promote a fair, transparent, and competitive marketplace. Waiting for a second. Or do we need to kind of go ahead with the brief comment?
We do need a second. You got it.
All right. I just want to speak briefly to why this issue is urgent and why it deserves attention now. We recognize and respectfully disagree with the inference that's been previously discussed over the weekend that the document titled APhA Principles of Pharmaceutical Supply Chain Policy addresses our proposed concern. We feel the document does not reflect the emergence or the specificity that's required. APhA has always taken pride in being a forward-looking organization, but in this case, the reality of the policy environment has already moved ahead of us. Across the country, decisions are being made right now by regulators, legislatures, and through enforcement actions on pharmacy benefit manager practices and the structure of prescription drug supply chains. 39 state attorney generals are calling for action. They have sent a letter to Congress demanding addressing this vertical integration issue. And states like Arkansas have already enacted structural reforms, and Tennessee and West Virginia are taking action at this very moment. This is not a future issue. This is a present one. And the impacts are not abstract. They are showing up in patient care today. Our patients are experiencing delays in therapy, restrictions to access to clinically appropriate medications, and rising out-of-pocket costs. We're seeing continued pressure on pharmacies and closures of over 150 pharmacies in my state of Illinois alone in the last 2 years, reducing access points and instability in communities that rely on pharmacies as one of the most accessible healthcare providers. In Illinois and states across this country, we are seeing this firsthand. Policymakers are acting to address these PBM practices because of concerns around affordability, access, and outcomes. And we continue to see the downstream impact, particularly in underserved communities, where pharmacy closures translate directly to reduce access to care. When a pharmacy closes, access does not shift, it disappears. When access disappears, care is delayed. When care is delayed, outcomes suffer. This is why this is urgent. This is not simply a policy discussion about reimbursement or market structure. This is about whether patients can access the medications they need when they need them for the providers they trust. And it is about whether APhA has a voice in the decisions that are being made right now that will shape that access. Waiting until the next policy cycle means we are not part of that conversation when it matters most. We can continue to refine, debate, evolve policies as we should. We also want to be clear, we're addressing vertical integration that does not include designs like HMOs or health systems. And we have an amendment to address the caucus feedback that we heard this morning, and we are thankful. This is a vital issue. We should not be silent in this moment. This House has always stepped forward when the profession and our patients needed clarity and leadership. I submit that this is one of those moments.